Hi, everyone, and welcome to the first webinar of this year's Focus on Eye Health webinar series, Vision Policy Across the Landscape, the Lifespan. Thank you for joining us today from across the U.S. and the world. I'm Jeff Todd, President and CEO of Prevent Blindness. For those who visual assistants might help, I am a white man in my 50s, have a beard, wearing glasses, a blurry background, and a blue short sleeve shirt. We're pleased to be here with you today for our first webinar in this series. Since 1908, Prevent Blindness has been dedicated to preventing blindness and preserving sight, a mission we elevate through three strategic pillars: educate, advocate, and collaborate. We've championed eye health and safety by educating the public, advocating for equitable access to quality eye care, promoting the early detection of vision problems, and empowering patients and their care partners. Prevent Blindness and our state affiliates serve as a trusted resource for the public, patients, care partners, and eye care professionals, with the following impact in the last year alone. From a policy and advocacy perspective, we've had 8,150 plus engagements with members of Congress. We've had over 2.4 million people reached through screenings, referrals, exams, and treatment. 12,900 individuals have been trained or provided technical assistance, and nearly 1 million people have been directly educated with 3.7 billion media impressions to our resources. We thank all of those who've worked with us to elevate vision and eye health as a key aspect of overall health, education, employment, and ensuring the highest quality of life for all. We're proud that Prevent Blindness can serve as a convening organization to bring people together to explore these issues and how they impact millions of Americans and our friends around the world. For many of you, this webinar may feel familiar, as it's an evolution of our annual Focus on Eye Health Summit that we've held over the past 15 years. Designed to engage us all throughout the year, this series continues our longstanding tradition of bringing together diverse voices to explore vision from a public health perspective. This year's theme, Powering Partnerships to Advance Eye Health, reflects our focus on strengthening partnerships at all levels to advance innovation and sustainable solutions in policy, access to care, patient engagement, and research and clinical interventions. Throughout this series, we'll discover how partnerships can improve access, strengthen systems of care, and advance overall eye health. I'd like to thank the many sponsors without whom this event would be possible. Our platinum sponsors this year include the Alliance for Aging Research, Genentech, and Pharma. Thank you also to our many silver sponsors, seen here for their generous contributions. Recordings from today's session will be added to the Focus on Eye Health webinar series event webpage, preventblindness.org/FOEH, within a week. You can also access presentations from previous summits here. In addition, speaker and moderator bios and other resources can be found from this page. Please follow us on social media to stay updated on top of our latest events and vision and eye health information. You'll see all of our sites right here. And now I'd like to introduce our moderator for the Vision Policy Across the Lifespan webinar, Josie Cooper. Josie is an executive director of the Alliance for Patient Access. In this role, she serves as an advisor to the Vision Health Advocacy Coalition, of which Prevent Blindness is a member. The coalition advocates for patient-centered vision health policy. And now I'll hand it over to Josie. Thank you.
Thanks so much, Jeff. Good afternoon, everyone, and welcome to the first webinar of the Prevent Blindness 2026 Focus on Eye Health webinar series. As Jeff said, I'm Josie Cooper with the Alliance for Patient Access, and I am thrilled to be here to moderate today's discussion. Today's conversation is focused on vision policy across the lifespan. As I think folks know, eye health needs can look very different from childhood to adulthood, and into older age. And policy plays a really critical role in shaping whether patients are able to get the care, the support, and the services that they need at any stage of their life. Policy is the outcome of decisions around how we access eye care, how providers serve their patients, what ideas receive research funding, what treatments get to market and at what cost, and how our system promotes eye health outcomes. And I think we would probably all agree that at the heart of those decisions should be the patient voice. So we're very excited today to have a wonderful group of panelists with us, all of who have deep expertise and knowledge in eye health policy. So we're looking forward to hearing their perspectives on where the biggest challenges and opportunities are in policy, what stronger partnerships could look like, and where we go from here. So I'd like to briefly introduce today's panelists, and you'll see their headshots on your screen. Leela Baggett. Leela is the coordinator of the Independence through Enhancement of Medicare and Medicaid Coalition, also known as the ITEM Coalition. Sara Everett Brown, who serves as Senior Director of Government Affairs at Prevent Blindness. Scott Haber, the Director of Public Health Advocacy at the American Academy of Ophthalmology, and Dr. Araba Otoo, who serves as the chair of the American Public Health Association Vision Care Section, as well as CEO of Cherish, Eyesight, and Vision, Inc. So thank you all for being here. And with that, let's get the conversation started. So, to begin, I know I gave brief intros, but we'd like to ask everyone to just briefly introduce yourselves, who you are, what your role is, a little bit about your work and what you do to promote, vision across the lifespan from the policy lens. And Sara, I think we'll start with you if that's okay.
Sure. Thanks, Josie. Hi, everyone. I'm Sara Everett Brown, and I'm currently the Senior Director of Government Affairs at Prevent Blindness. I'm a light-skinned woman with light brown hair just past my shoulders. And today I'm wearing a brown sweater and two gold chains, and I'm sitting in front of a blurred image of my office. So Prevent Blindness is a national level patient advocacy organization, and our mission is very clear. We are here to prevent blindness and to preserve sight in the United States. And so our approach to vision and eye health is to help strengthen our national system of care to ensure that everyone, no matter what age, race, community, geography, or financial means, can access the right care at the right time and live their best life with the best vision possible. But to do that, we need policies in place that help prioritize early detection and prevention, and we need the right research, funding, and infrastructure to help understand how people at the highest risk of vision loss can access care, and we need the right policies in place to make that eye care affordable and accessible. All of these strategies, when deployed together, in addition to the many that I'm sure my colleagues here today will surely raise, will help set that foundation for good vision across a lifetime.
Thanks so much, Sara. Scott, do you want to go next?
Sure. Thanks, Josie. Scott Haber, I'm the Director of Public Health Advocacy for the American Academy of Ophthalmology. I'm a light-skinned man with a white-collared shirt here in my office in Washington. My role for the Academy spans both a policy portfolio on the regulatory side and the legislative side. I advance the Academy's policy priorities in the area of workforce, our engagement with the FDA and Congress on treatments that our physicians need to treat their patients and also that patients rely on for quality eye health. In addition to that, I do our strategic initiatives, including those that expand access to care outside of the ophthalmology office, which leads me to engagement with community health centers, rural clinics, free clinics, and those that are non-traditional eye care settings. I have worked here for over a decade and have been able to have the opportunity to advance policy for ophthalmologists, but also our patients, and think that there's quite a bit that we can do together to continue that advancement.
Absolutely. Thanks so much, Scott. Dr. Otoo,
Yes. Thank you, Josie. Hello, everyone. My name is Dr. Araba Otoo. I am a Black woman with dark hair. I am wearing a pair of glasses, like hexagon pair of glasses and a gray sweater with little black bows in it. I am an optometrist, I am a clinician, and I am joining this webinar from Chicago in my capacity as the chair of the American Public Health Association Vision Care section. I am also the founder of Cherish Eyesight and Vision Incorporated. The APHA Vision Care section is an advocate to ensure that there is equality in and access to vision and eye health care, as well as ensuring that there is inclusion of vision in public health policy. The section brings together multidisciplinary membership dedicated to the public health aspects of vision care, including promoting eye health equity, advancing research, and advocating for accessible vision services across all populations. Thank you.
Fantastic. Thanks so much, Dr. Otoo. And Leela?
Thanks so much. My name is Leela Baggett. I am a partner at Powers Law Firm in Washington, D.C. I am a light-skinned woman with blonde hair, and I'm appearing today in a black suit. As an attorney, I want to emphasize that my remarks today are solely for educational and informational purposes. Nothing I say should be construed as legal advice, nor does this presentation create an attorney-client relationship. But now that that's out of the way, I am a coordinator of the ITEM Coalition, the Independence Through Enhancement of Medicare and Medicaid Coalition, which is a national consumer and clinician-led coalition of over 100 members advocating for access to and coverage of assistive devices. Prevent Blindness is a member of the ITEM Coalition's low vision subgroup, which focuses on addressing the lack of coverage in the Medicare space for low vision devices. Thanks.
Thanks so much, Leela. And by way of visual introduction on my side, Josie Cooper, I'm a light-skinned woman with brown hair wearing a navy dress, coming to you from my office in Washington, D.C. So thank you all for being here. Very excited about this conversation. Really wonderful to have such a thoughtful group with such broad experience. And so, we're talking about vision care across kind of the spectrum here. And so I want to start with eye health in children. Sara, Prevent Blindness has worked with congressional champions to advance important legislation on children's vision and eye health, the Early Detection of Vision Impairments, or EDVI for Children Act. Could you talk a little bit about your work around the bill, why it's so important for children's vision, and then the role that partnerships play in advancing bills like this?
Absolutely. So here at Prevent Blindness, we're so excited about this legislation that has been introduced and then reintroduced in the House and has been in existence for about 2 years now. I'll explain what the bill does in just a moment, but I just want to share that we are up to 20 co-sponsors in the House. It is a bipartisan bill that helps to establish a federal program on children's vision and eye health in the United States. And as of today, we are up to about 111 organizations across the United States, some of which are sitting at this table here with me today, that have endorsed this legislation. And these are groups that are not just residing in the vision community. We have groups that have that introduce or that represent providers, children and families, educational groups, and industry as well too, that have really supported this bill and the aims that it hopes to achieve. So what the legislation does, the Early Detection of Vision Impairments for Children, we're calling it the EDVI Act. There's a good reason why we're calling it that. And that's because it models a program that has been very successful in children's hearing and creating a system of care around children's hearing. So the EDVI Act would create grants for states and communities to build, develop, and implement systems of care for children's vision and eye health, and really create that sustainable resource funding stream so that they could be able to look at areas that need improvement in children's vision and eye health at the community level. And the bill would cost about $10 million per year. $5 million of that would go toward grants for states and communities, and we believe that that would initiate first a competitive grant process. And there's a list of activities that grantees would need to adhere to in the legislation to, again, build that system of care for children's vision and eye health. And then the bill also creates some technical assistance funding. So any state that does not receive that first round of grant funding would be able to benefit from updating their evidence-based best practices and learn from other states about what they can do right now to advance children's vision and eye health at the community level. And I think the unique thing about this bill is that not only does it create something that doesn't currently exist, which is actually pretty cool, but it creates that opportunity for states to learn from each other. And it also builds on a very long-standing federal-state partnership by establishing that grant relationship. So we're really excited about this legislation. There's definitely more information on our website and happy to continue talking about it here.
Thank you so much, Sara. I know our organization has endorsed that bill. We're very grateful for the leadership of Prevent Blindness on this issue. So thank you for that. Now, as we look at kind of moving into our adult years, as we think about the importance of eye care in the adult population, want to talk about some of the important policy considerations in our working years into middle age adulthood. Scott, can you talk to us a little bit about that?
Of course, thanks, Josie. And I would echo your comments to Sara about everything that she shared on EDVI. That's certainly a academy priority and an important policy consideration for all of our groups to work towards advancing. In the working age, I mean, we continue to prioritize the importance of working adults to get access to screenings and examinations that would identify things. I think, many times we move out of from the frame of thinking about whether it's ophthalmology or optometry or eye care is something that's impactful in the early years and then impactful later in life. But ultimately, the working age folks, they need high care, they need access to care, they need quality vision. For us, our policy priorities many times are making sure that decisions are being made between the physician, the practice, the eye care provider, and the patient. So the Academy works to address policies around prior authorizations, things that put up barriers between patients and the care that they need. Same thing I would say with step therapy, which is a similar protocol. So we look to remove those barriers, advance policy considerations, and advance legislation that address those and more are empowering the patients and building that relationship between them and their physician.
Thanks so much, Scott. Dr. Otoo, I know you have a lot of experience in this area. Can you share your perspective?
Sure. Thank you. And I would also echo what Scott has just said. As we grow older, we move through working years and middle age. Um, Eye health becomes important. Policy pertaining to that becomes very important because we need to maintain or improve the quality of life, right? As we grow older, we have such a significant involvement in workspaces. We need to make sure that productivity is top notch. It's also at this age that chronic diseases begin to creep up. And so policy considerations should include trying to increase access to preventive and routine eye care. Many adults, just like, Scott said, most of the time we focus on kids and elderly, leaving people middle age. Much attention is not given to them. But this is a population that also does not really prioritize eye care most of the time because of the costs associated with it, the lack of insurance. So policies should focus on expanding coverage for preventive eye care, whether it's private or public insurance. We should work hard reducing out of pocket costs, prioritize improving access in urban and rural communities. As I've already talked about, workspace is also important. A lot of us, just as we are all here, we are very much on our screens and our phones all the time. And so there's a lot of digital eye strain. So this population should very much be educated about, best habits. The quickest thing that comes to mind is 2020 rule, take breaks when you're on the screen for a very long time. And just, giving screenings to workplaces, if it's like a welding facility, make sure that people have the right, safety glasses. So that's something that comes to mind. Another thing that I want to talk about is I mentioned how chronic diseases begin to creep up. So when you think about diabetes and high blood pressure, they all have visual implications. So people should be educated people who hopefully, when you know better, you do better. So we should make sure that people know the visual implications of these chronic diseases and make sure that there is some sort of coordination between PCPs and primary eye care providers, or, just eye care providers. I also thinking about addressing equity and disparities. So policies should think about that. We should think about the social determinants of health. Sometimes transportation to the eye care doctor. That's something that policies can look at. And we have to be intentional about providing culturally responsive eye care services, given how diverse several communities are. And then when you think about public health, we are very much lacking in data when it comes to eye care. So that's another thing that policies could be intentional about in terms of having national surveillance when it comes to vision impairments and eye diseases. We need to make sure that we have different metrics so that we can accurately quantify prevalence of different eye diseases so that we are not just making decisions on a whim. Yep, that's that.
Thank you so much. I think there's a lot for us to consider. And Leela, I want to turn to you next. So the ITEM Coalition focuses on enhancing Medicaid and Medicare to address the eye health needs of the aging population, specifically through coverage of low vision devices, assisted technologies, for those who live with low vision, loss of functional vision, blindness. What can you share about eye health needs in our golden years and how, Medicare policy aligns with those needs or doesn't?
Certain. Yeah, certainly. So as people age, vision becomes deeply connected with independence, safety, mobility, mental health, and just the general ability to remain engaged with community life. Vision loss is not simply an inconvenience, it's associated with increased fall risk, social isolation, difficulty managing chronic diseases, and a greater reliance on caregivers. Now, unfortunately, Medicare policy only partially addresses the realities faced by people with vision loss or vision-related conditions. Traditional Medicare, which I'll refer to as, Part A, Part B, so not Medicare Advantage, but traditional Medicare does cover limited medically necessary eye services, so cataract surgery, some glaucoma screenings. However, traditional Medicare generally excludes routine eye exams, eyeglasses, contact lenses, and low vision devices. Low vision devices are items such as handheld monitors, magnifiers, and other items that may alter the size of the image, the contrast, brightness, or color of an object to enhance its visibility to the user. So these significant gaps in Medicare coverage have serious real-world consequences. For many people with low vision, these devices are essential tools to support independent living and safety. So without access to appropriate low vision devices, for instance, or rehabilitation services, individuals may have a difficult time reading medication labels, reading or reviewing their medical documentation, financial documentation, navigating a public space safely, managing employment, or even having just full participation in their community. I want to distinguish between the traditional Medicare, again, Part A and B, versus Medicare Advantage, which is also known as Part C. So by law, every Medicare Advantage plan, MA plan, must provide what is referred to as basic benefits. And those benefits are all benefits covered by traditional Medicare under Part A and Part B. So for instance, cataract surgery. MA plans may additionally offer supplemental benefits beyond those available under the traditional Medicare program. And that can include routine vision care, although the availability and the scope of coverage can vary by plan. So it's important for beneficiaries and their families to understand the distinction between the traditional Part A, Part B Medicare versus the Part C Medicare Advantage plan when evaluating both vision coverage but also broader healthcare needs. I'll note that while some Medicare Advantage plans may offer supplemental vision benefits that are not available under the traditional Medicare benefit, MA plans also impose occasionally restrictive provider networks, and they require prior authorization that Scott had mentioned earlier before obtaining certain items and services under the healthcare benefit. So beneficiaries really do need to review their benefits and risks associated with each type of coverage to determine what options best align with their medical needs, their preferred providers, their financial circumstances, and the risks that are associated with accessing necessary services and supports.
Thanks so much, Leela. I think that's an incredibly helpful overview. So a related question, I'll pose this really to the group. As you look at childhood, adulthood, older adulthood, where do you see the biggest gaps in vision and eye health policy today? And Sara, since you talked childhood vision health, can you start?
Sure. Yeah, that's always a good place to start right at the beginning. To be honest, I would say that the biggest gap in policy is that we don't have any dedicated efforts on children's vision and eye health. It's very absent from any approaches at the federal level across the spectrum of child health and development. We see a lot of really successful approaches around oral health and hearing, speaking of the sensory category, and certainly other physical aspects of health and mental and behavioral, as we very well should. But there's nothing that's dedicated specifically for children's vision and eye health. And where we are because of that is states and communities are all kind of doing their own thing. They have different policies and practices in place. They have different requirements for screenings and at what age and at what periodicity. And some of them are probably not even using tools that are up to base evidence-wise, and they might be using protocols that predate any of us on this call right now. And this is a problem because this creates a lot of health disparities and outcomes, not just in eye health care, but childhood development, and even looking at some of those academic learning outcomes and school scores and things. And so across the country, what we're seeing is that, eye care is coming down to where you live, your financial means and your circumstances. And I think that right now that is the biggest gap in policy, is that we don't have anything that can coordinate this across the United States and make sure that kids are getting the right eye care at the right time.
Absolutely. Thanks so much, Sara. Dr. Otoo, what about adulthood? Can you share your perspective?
Sure. So kind of echoing what Sarah just said, the fact that we don't have anything, for children and just for vision and eye health in general. The biggest gap that I see or think about is the fact that vision and eye health is very much separated from overall health in this country. We treat it like it's not healthcare, or it's an afterthought, or it's an extra body part that was added to our body. It's not treated as part of our health, and I think that needs to start changing. And because of this, the results, prevention, access, and long-term vision outcomes are frequently overlooked when it comes to policies. So as we talked about previously, as we grow older, chronic diseases become a thing. A lot of us know that these chronic diseases do affect the eye. They are actually leading causes of blindness, nationally and globally as well. But there is very limited integration between PCPs and public health systems and eye care providers and even chronic disease programs. I would say that things are improving over time because as a clinician, we are very much intentional about, PCPs sending patients to us and we sending patients you send in a diabetic report back to the patient. So things are improving, but we do have a lot of work to do to make sure that this fragmentation does not exist. Another gap that I would mention would be simply cost. I'm sure you guys have all heard about how costly it is. People can pay for it. Insurance becomes an issue, or it becomes a deterrent. So once again, that's a gap that has long existed and very much something that we should be focusing on and trying to address as best as we can.
Absolutely. So cost and then fragmentation. I think the interesting thing about the fragmentation is, we learn more and more all the time from the science how interconnected all of these chronic diseases are. And at the same time, we don't treat it like that from a policy perspective. And that does need to change. So I'm with you on that. Scott, anything that you would add?
No, I think, joining both of them, we do have gaps here in the eye care space. I think from the pediatric side to the adulthood to what Leela shared about with, an exclusionary policy that the academy and many of the stakeholders have been trying to remove for years. With that, I would say that there's a lot of opportunity. I think one of the things that we haven't mentioned yet is research. Almost all of our organizations or the organizations that we represent and the folks that are on the call, Many of their groups too are very dedicated to research, increasing funding for the National Eye Institute, increasing the small amount of funding that the CDC has for their Vision Health Initiative. But all of that can serve to educate us on innovative treatment options, innovative ways of reducing some of these barriers to care, really novel treatments. We have advocated for many years on the NEI. Some of the most brilliant innovations in the medical sphere are coming out of the NEI. That includes those around artificial intelligence. First FDA approval of a AI-based platform came out of the NEI and supported by the NEI. So there are a lot of opportunities. There's a lot of opportunities for research, but I think all of these are worthwhile, and we have to attack all of these challenges cumulatively and all together.
Thanks, Scott. And then Leela, I know you've already sort of identified a challenge, but anything that you would add?
Yeah, and I'll put a little bit of a finer point on the question. I think one of the most significant gaps in Medicare coverage that could be potentially addressed without congressional action is the low vision aid exclusion. So as I mentioned earlier, the Medicare statute expressly excludes coverage for routine eyeglasses and routine eye exams, but Congress was silent on the coverage of low vision devices. They did not explicitly prohibit coverage for, say, magnifiers, video monitors, minifiers, prisms, the head-borne devices. And in 2008, the federal agency Centers for Medicare and Medicaid Services, which governs the Medicare program, they finalized a regulation commonly referred to as the low vision aid exclusion, which interpreted that statutory eyeglass exclusion so broadly to exclude low vision devices from Medicare coverage, even though those devices are medically necessary and functionally distinct from corrective lenses. The ITEM Coalition, which I coordinate, believes that this interpretation extends beyond what Congress intended, and it does create a categorical barrier to coverage for beneficiaries with low vision who rely on those devices to maintain safety and independence. When the agency promulgated that regulation, they provided little to no rationale for this sweeping policy. And in fact, prior to the regulation, some administrative law judges that focus on Medicare, so not your traditional judge, but they're kind of specialty judges, they began to interpret the Medicare statute to allow coverage for certain low vision devices through what's referred to as an appeals process. So because this exclusion was created through agency rulemaking as opposed to an act of Congress, that means that CMS, again, the federal agency under the Trump administration, has the authority to revisit and reverse its policy without congressional intervention. So us stakeholders in the advocacy space, including Prevent Blindness, including the ITEM Coalition, we are urging the Trump administration to reconsider that regulation and allow low vision devices to be treated differently from eyeglasses for purposes of Medicare coverage. And Prevent Blindness and the ITEM Coalition are in fact meeting with CMS, again, the federal agency, this week to discuss eliminating this barrier. And we're also going to be asking the Congressional Vision Caucus to see if they'd be willing to also weigh in with this administration.
Thanks so much, Leela. I think what's so great about this panel is you all have such a wealth of experience addressing very different, in some ways, pieces of the vision policy conversation. And one thing that is interesting about the time we're in, it's a very challenging time from a policy perspective. There's a lot happening. There's a lot changing very quickly. I'd like to ask really each of you who wants to share, what are some of the obstacles that you're facing as you're trying to make policy change? And is there anything that you've done to, adjust your approach or change kind of how you're looking at the problem? And Leela, I'll start with you if that's okay.
Absolutely. A major obstacle to expanding Medicare vision coverage is the complexity of the federal policymaking process. Medicare policy is shaped not only by statute, done by Congress, but it's also by agency regulation, administrative interpretation, budgetary concerns, and other political priorities. So just to back up a little bit to give you some background, as we probably all know, the legislative branch, which is Congress, creates the laws that authorize and define the Medicare benefit. The executive branch, which is here the Trump administration, including the Centers for Medicare and Medicaid Services, they're responsible for implementing and administering those laws through regulations, guidance, coverage determinations. So in the vision policy space, that distinction is very, very important because coverage can stem directly from statute, which can only be, quote, corrected by Congress, which can be very difficult in this political landscape, while other coverage barriers really stem from agency regulation interpretation. And that can be overturned by CMS, the federal agency, alone without Congress. The current political and fiscal environment can also affect the likelihood of policy changes. As we all know, we are in a midterm election cycle, so Congress is generally less inclined to pursue changes that could be significantly increasing program spending. And because expanding coverage for routine eyeglasses, for instance, or eye exams under the traditional Medicare benefit, because that would increase program spending, legislation on this matter is unlikely in the near future. I want to just be candid about that. But knowing that, many advocates are now shifting their focus on policy changes that can be achieved through the administrative action alone by a federal agency without Congress. So as I mentioned earlier, because the low vision aid exclusion was created through CMS regulation alone, we could revise that through the agency without congressional intervention. So again, the Item Coalition is focusing their policy in the short term on the administration as opposed to Congress through legislation.
Thanks so much, Leela. Really helpful information. Scott, anything you would add?
Yeah, I mean, I think Leela did such a terrific job outlining sort of the challenges that we face, especially around that specific policy idea. I mean, um, things, and not only does good policy take time, but really nowadays any policy takes time. It can take multiple Congresses, it can take multiple administrations to achieve policies, both big and small. I think, sort of to what Leela was conveying, I mean, stakeholders, policy professionals, everybody needs to have flexibility. Sometimes there are going to be opportunities and there's going to be a window for huge policy change that can impact our members, our patients. And other times you're going to have to sort of narrow down your priorities to that which you can achieve in a certain window. I think a lot of the times it's difficult not to get discouraged about the length of time, and a lot of that is just the way society is now, where if you know a problem and you're looking for the answer, you can pick up your phone or open up your computer. With policy, that's just not how it works, and to be honest, I don't know if that's going to be the way it works moving forward. You're going to need to be patient. And when the window opens, you're going to have all the stakeholders ready to move forward and achieve.
Thanks, Scott. I think that the point of the time that it takes is a really important one because when you're not in Washington, it I think feels particularly slow. So I wanted to move to another question. And Dr. Otoo, you touched on this earlier, but I want to come back to it. As we think about access, when we think about systems change, equity really has to be front and center. Can you talk about who's, really at most risk of being left behind by current policies and what a better, more equitable policy approach might look like?
Sure. I think that the group of people who are at risk of being left behind would be the working age adults. And that is because we have, for very good reasons, we tend to focus on kids, which we are doing a great job, and by all means we should. And as we grow older, again, medicine has improved so much that a lot of people are living longer with, chronic diseases. And again, these chronic diseases more often than not affect vision. So therefore, we focus on that. And so we have to be careful not to miss the people in the middle, right? Again, this is the population that doesn't really pay much attention to getting preventive eye exams because, oh, everything is fine. But we know very well that the fact that you can see does not mean that you have good eye health. So I feel like this population is, we should be intentional about, hey, we are going to address things for kids, we are going to address things for adults, and we need to make sure that we don't leave this group behind. We already talked about how, again, all of us are here on our screen, so digital eye strain is a thing. We all work really hard in different spaces. Occupational hazard is also a thing. There is insurance instability. So, I can't reiterate my reasons for thinking that this group is the group that will be left behind if we are not cognizant of it. So, an approach is simply to be intentional and going back to, previous questions about policy considerations, like everything that we talked about there, where we should work on making things affordable, improving access, encouraging, just merely educating people and helping them understand the reasons why these things are important. And come to think about it, as many of us would know, a lot of vision impairment is preventable, right? So in the public health space, we preach and should be preaching prevention. So once again, if a lot of all these vision impairments is preventable, why are we not preventing it? We do not have an excuse. So those are my thoughts. Yeah.
Absolutely. Sara or others on the panel, anything to add?
I just want to share that, equity is one of the principles that is behind the EDVI Act, and I'll explain how that's possible. The way that the legislation is written is that it creates grants for states and communities. And yes, there are about 6 activities that grantees that receive EDVI funding would be required to demonstrate upon receipt of this grant funding. But aside from that, it's written in service of a system of care for children's vision and eye health, and there's nothing that specifically tells states how they implement that system of eye care for children. And so, with that equitable approach in mind, states are able to use this funding in a way that best suits their states and communities by addressing their first most urgent need, whatever that is. So there's nothing that says it has to be done a certain way over a certain other way, or it has to emulate what one state or what community is doing. There's enough flexibility within that language and those 6 activities in service of a system of care that helps to address children's vision and eye health in a way that makes sense to that population without putting those guardrails on it for how that funding is spent outside of that system of care. So hopefully this is the best way forward to address children's vision and eye health. And to go back to the question and answer that, Josie, I think without that system of care in place, we're already leaving children behind, and we're in danger of leaving the next generation of children behind without addressing their care, and leaving them behind without that good, strong foundation of eye care in the first place is leading to the problems that Dr. Otoo and Scott and eventually Leela will, their populations will have to face as throughout their own lifetimes.
Absolutely. Thanks so much, Sara. Leela, I saw you came off mute. What would you add?
Yeah, I'll just add, when Medicare or really any other payer does not cover a medically necessary device or service, patients are really left with 2 options: either go without the care that they need or pay for it out of pocket. And so for some, for instance, older adults with fixed incomes or those who are dually eligible for both Medicare and Medicaid, paying for care out of pocket just may not be realistic. So I would just add that people who are at risk for being left behind includes those who are not fiscally able to absorb those costs. And a more equitable policy would, of course, be if Congress and administration could recognize that vision care is medical care.
Mhm.
Absolutely agree with all of that. I'm cognizant of time, so I want to keep moving on to the next couple of questions here. But the theme of the Focus on Eye Health webinar series is partnerships, which I love because in what we do at the Alliance for Patient Access and the Vision Health Advocacy Coalition, it's all about partnerships. We all as organizations do a lot of work to form coalitions to advocate from a shared voice. Would ask folks in this group, what value do you place on these kinds of partnerships to advance policy goals? How do you decide what partnerships, you'll participate in as an organization? And Scott, I might start with you if that's okay.
Sure. Um, well, I think everybody's going to chime in and say partnerships and coalitions are incredibly important because we all work together on so many of these important things. How does the Academy decide? I mean, are we in alignment on the policy priority that we're trying to advance? Can we build coalitions and relationships with those even outside of the sort of vision and eye health space? We look to do anything. I think many of the times, even at the most granular level of whether it's lobbying or policy making, we can always make our pitch, but one of the first things we'll get back from staff or regulatory heads is, well, what does this other stakeholder think about it? And that's why it's important to build coalitions and relationships, even if with those who you may disagree, to sort of understand where the sticking points are and try to identify what you can do to compromise or to at least move forward with an understanding of where everybody's at. But rarely can a singular group or stakeholder advance meaningful policy here in Washington or even at the state level. It takes these partnerships and these coalitions with a shared voice to impact change.
Absolutely. Other thoughts from the group?
I was going to say I love this question because, Scott and Leela and you, Josie, we work very closely with coalitions that each of these organizations are part of to advance vision and eye health policies. And Dr. Otoo with APHA just coming on board as one of the most recent EDVI Act supporters. You're in there as well, too. And, when we look at coalitions and partnerships and how to engage with them, the first thing that we look at is, what are our own policy priorities and our agenda items, and what's most important to us, and where on the spectrum are we in terms of how we can influence something. And so, we definitely do our due diligence and speak to other groups that are members and hear what experiences they have. And that's how we become part of these organizations and work in partnership and can be at the table for things like the meeting that Leela just mentioned is happening later this week. One thing I will say too, as far as coalitions and partnerships, is not everyone does the same thing. Not everyone can offer the same benefits and the same activities. Some are incredibly valuable just for information sharing and just for understanding where something that you may not be able to put your first finger on, where exactly that is in the process of legislating and governing. And so that's really valuable too, even if you don't have a seat at the table or you have meetings with them all the time. If you can still get information from them, that's incredibly useful to you and the mission that you're trying to resolve. And then other organizations are much more active than others. And if you can be part of that, that's great. But you just have to make those decisions about where does your organization fall in relation to the policy that they're looking to advance, and how can you help advance their mission as a member of that organization.
Absolutely. I think that's a great point, Sarah. Particularly not everybody does everything, and you don't have to. That's the goal of coalitions, is to create capacity, create opportunities for partnership and the chance to weigh in on things that others might not always be able to. Dr. Otoo?
Yes, thank you. Thank you. So basically, just wanted to echo what has already been said. There's power in numbers, and we know very well that no one individual organization can, advance this full scope of vision and eye health challenges all by themselves or him or herself. So partnerships are very important. It's even more meaningful when you have shared values. You have a clear commitment, which is geared towards improving visual outcomes in different communities, which all of us here are very much, passionate about that. I just wanted to bring a PHA Vision Care section to light, where the mission is to promote health and well-being with an emphasis on eye health, and doing that using interdisciplinary collaboration. So the group is very diverse, very much so a lot of clinicians, optometry, ophthalmology. We have people from the VA, we have Prevent Blindness, and a number of folks here are members of it. We have Save Foundation, we have folks from the CDC as well. So bottom line, there is power in numbers, and we should all be working together. And partly so we don't have to reinvent the wheel. It just makes work easier, and we are able to drive things forward faster that way.
Absolutely. I love that. And related question that hasn't come up yet is, how do we incorporate the patient voice? We know how powerful, the voices of individuals are, the power of the patient experience and the provider experience too, I think, Scott. But can you guys speak to, how you incorporate patients into your work? Sarah, maybe I'll start with you.
Sure. Well, I'd say that, patient stories, histories, and experiences are incredibly valuable to policymakers when we're speaking about some of these policies. We can give them data as long as the day is, far, but what really sticks out in their minds is how somebody experiences something because of a policy decision that was made. I personally used to work in the Senate. I did long time ago, longer than I want to admit here, but long enough. And even as a staffer, I was working on energy and environmental policy at the time. And I can still remember one group that came in and showed me a baby pillow that, she said, this pillow has fire retardants in it, and I'm nursing my child on it. That was so long ago, and that was one of the only things that I can remember about that meeting. I don't really even remember the name of the bill or what the number of it was, but I remember her saying that and just putting it to me in a way that helps me understand, why is it important that my boss vote for or against whatever bill it was at that time that we were looking at. And that was one of the best reasons that I gave to him to consider that of just these two things do not belong together. And so this is a really compelling reason. And we're in a position, in that time as a legislative office to do something about this. And so I would really encourage anybody. I know it's incredibly vulnerable to share your story, but it really does make a difference. And, in just a couple of weeks, we're bringing about 100 advocates to DC who are going to do just that in service of the policies that Prevent Blindness has identified as helping to prevent blindness and preserve sight. So I really encourage everybody to lean into that and learn how to do that in a way that helps you feel empowered about it. But I promise that, it really does make a difference, and it helps stick in the minds of policymakers who are confronted with so much information they don't know what to do with.
Mhm.
Absolutely. Thank you so much, Sara. And I'm going to keep us moving because I want to make sure that we have enough time for our last question. And Sara, I'm going to make you start on this one, but let's just talk a little bit about, where there's opportunities to make meaningful progress. Where do each of you see the biggest opportunity for policy to actually improve access to vision and to eye health care?
Well,
Sara?
thanks. I'm gonna mention the EDVI Act again. I think that this is a massive opportunity. Right now in this environment of legislating, we're seeing a lot of cuts to various social programs and healthcare access avenues, and the EDVI Act is something that can really come in and help to kind of close some of those gaps. The challenges, and Leela brought this up earlier, is the cost of things. EDVI Act would create a new program, and this is just not the right environment for that. But at the same time, we're not settling on that. We're looking outside to the, organizational community and, learning who our other supporters could be of this bill and what they can bring to advocate for this legislation, because this is something that can help not just parents and families and ultimately children, but it can give providers the right resources they need. It can give states and communities the right information to be able to build that system of care. And so there is opportunity. Sometimes it's just a matter of waiting for the right time to take on that opportunity and being ready for when that opportunity arrives.
Absolutely. Thanks so much, Sara. Dr. Otoo, we'll turn to you next.
Sure. So an area that I think we have opportunity for policy is to better integrate eye health with a broader healthcare system. Once again, when we are able to establish that, blindness is preventable, vision is important, quality, all the reasons why we should be preventing blindness, hopefully the value of it will be high enough for um, medicine or healthcare to recognize eye health as important so that these conversations that we are having here will not be, we will still have them, but it will not, it will already, everybody will already know that it's very much important, right? So I think the opportunity will be to work towards integrating eye health into the broader healthcare system. And again, we've already talked about cost, insurance. It's a very multifaceted problem. So kind of addressing all these different things in tandem so that, again, it's all very much related. Even if we increase access, now the person has access to, access could be defined in so many ways. But let's say you provide, you help, you ask a doctor to go somewhere. Now they have a doctor. How are they going to pay for that, right? So we have to address costs. But essentially, I think it's important to help people understand that eye care is important and it's part of overall healthcare.
Absolutely. Thank you, Dr. Otoo. Leela? last thoughts from you?
Just briefly, the clearest opportunity on the Medicare space is to rescind the low vision aid exclusion so that beneficiaries can seek coverage of their medically necessary low vision device. And I'll actually kick it back to Sara to talk a little bit about a letter urging CMS to eliminate that exclusion on Prevent Blindness's website.
Thanks, Leela. Sara, did you want to add to that?
No, just wanted to say, Leela was one of the benefits of coalition partnerships is that Leela helped to draft this letter for us to use, and we're posting it on our website. And this letter would go to Dr. Oz, who's the administrator for CMS, and urge him to consider rescinding the low vision aid exclusion. And so if you're out there and you're listening and you're wondering how you want to get involved, this is a great way to elevate your voice, encourage others to go and take a look at that and to use their voices.
Thanks so much to both of you for your work on that. Scott, final thoughts?
Sure, I'll wrap us up. I do want to say that, we have had some downer conversations here about the impacts of cost and how cost can really be a barrier to passing things in the short term. Same things with sort of an unstable environment and sort of just the lack of laws that are being passed in general. But I would say, specific to what Sara shared around EDVI, I think it's meaningful to be able to get up on the Hill for people to advocate at the grassroots level for children's vision. I think any opportunity to share that there's inequities across the country with how children have access to care, and the importance of it is important. Obviously, in the short term, the shortest of terms, what Leela has shared about our opportunities to meet with CMS again and really convey to them that this is a challenge that can be addressed administratively, and it would be important and meaningful for many patients who do not have the access that they need to low vision devices just because of a policy. And then I think to what Dr. Otoo said, I mean, we continue to convey everything for the not only access to care, but for the working age adults. I do think in the short term, there's an opportunity to address some of the things like prior authorization that are putting up barriers between patients and the care that they need. I think that there has been just so much outrage at the sort of granular patient level about care that is needed, but is unfortunately delayed. And so I am optimistic on that as something that can improve vision and eye health for patients with just a little bit more momentum.
Thanks, Scott, and I appreciate the point on optimism. So that concludes today's panel. I want to say a huge thank you to all of our panelists for sharing your insights and your expertise. I think it's a great reminder that, advancing policy takes strong partnership. It takes thoughtful folks looking at the policies and a real commitment to equity and to access. And before we end, I just want to remind folks about the next webinar in this series called Collaborative Solutions for Expanding Eye Care Access in Special Populations. This will take place on Thursday, August 6th from 2 to 3:30 Eastern. As the second webinar in the series, it will share practical strategies and actionable ideas for building and strengthening partnerships to advance eye care access for foster youth, for refugees, and for tribal communities. We hope you'll join that webinar as well. And thank you to everyone for taking the time to join today. Hope everyone has a wonderful day.
Thank you for watching. To learn more about the 2026 Focus on Eye Health webinar series, please visit preventblindness.org/FOEH.